Good morning. I bring you greetings from Amsterdam, and I was hired to argue against the cost effectiveness of robotic surgery in the head and neck. My opponent just argued that he can do a surgical procedure with a robot. He may even be able to do it with a bovie. And he also argued that there are 20 surgeons in the United States who are accredited to do this surgery within the two trials that are on, Bob Ferris's and Chris Holsinger's. So that's a huge amount, I must admit, 20 surgeons to be accredited to do this. So I don't need any fancy slides of young women. And I can simply stay with the facts because they will tell the story, and it's not about Taxol either. In fact, my point is very easy. I have nothing to disclose. So this is the fancy apparatus that Greg and was just talking about. So we have it, the urologist bought it. Again, it's not the issue of being able to use it, but are we spending too much money? So first of all, we analyze the motion. We're talking about robotic assisted surgery, that is TORS for the oropharynx, supraglottis, or even the unknown primary, or other indications like the skull-based thyroid, or even free flaps and neck dissections have been done. And we talk about value, i.e. cost effectiveness. What is cost effectiveness? Bevan has already given us a brief overview, and we're talking about the right upper corner. So it is more costly, but if it's also more effective, then we talk about a positive outcome. And as long as we are above this cost effectiveness threshold, we would be able to acquire the apparatus and to use it. Again, it's not about being able to, but is it cost effective? So what's the cost of the robot? We've heard it already. It's somewhere in the range of 1.5 to 2.3 US$ per system. The yearly maintenance costs are $125,000, and the cost of the instruments $400 to $500 per case, and that's widely advertised in the lay press as well. The additional cost of robotic surgery, if we assume that the capital equipment is amortized in 7 years, the robot will add more than $1,000 per case if used for even 300 procedures, which is quite a lot each year. So I could stop my argument here and assume that I have convinced you all, but I will just continue with some evidence. About the robot itself in head and neck surgery, there's really not much. I said I will talk about evidence. I've looked up in the literature. I come up with the same papers that my opponent came up with, but I just turn the argument around. And what is there out in the literature? It's mainly on oropharynx and thyroid, and it also depends on the way we look at the problem. That is, do we look also at indirect costs, for instance, and who is the payer? The main arguments of the proponents, however, and that doesn't differ whatever article you read, is that a robot is already in place in your hospital because of other high case volume groups and need not to be purchased by the head and neck team. I think Greg just mentioned that as well. So we look at the prime example of the high case volume specialty that uses the robot, which are the urologic surgeons, of course. They use it mainly for prostate, and in their literature they report higher costs and somewhere in the order of equivalent efficacy for robot-assisted laparoscopic prostatectomy in contrast to the laparoscopic prostatectomy. You can see here that it's used more often. Patients may want it. It is used more often, but it is simply more costly. Even the urologists argue this. So if we try to dispel this myth, there is a reduction of blood loss and somewhat shorter length of hospital stay. But even with the high volumes of robotic-assisted procedures, the decreased costs are not sufficient to reach cost equivalence compared to the usual laparoscopic radical prostatectomy. I don't invent this, of course. This is just out there in the urologic literature. So what's their situation? They say, at least this author in Current Opinion of 2 years ago, he argued that the added capital equipment and costs are not yet balanced by proven advantages that improved survival, quality of life, and reduced long-term costs. And these were just, I think, also the arguments that Bevan put out in his introduction. So the prerequisite for using it and for it to become cost-effective in the future is a reduction in cost of the robot itself and the instrumentation. And if we look at a paper of some years back in the New England, we find that compared to open procedures for other kinds of general surgical and gynecological procedures, it is 2 to 3 times the amount in costs of using a robot compared to using a open approach. So nothing about effectiveness, but just about cost. And of course, we all want to work with this very novel and machine that uses about 3 times as much theater space as a normal theater would have available. But the proponents argue that you can have better visualization of, for instance, the base of the tongue. So what about oropharynx? What are the pertinent unanswered questions? First, we witness a change in epidemiology, treatment de-escalation, and the transoral approaches, be it with the laser or the Bovi, are simply used more often than in the past. So does TORS plus or minus RT or chemo-RT result in better quality of life? Is it more costly than open? Is it more costly than transoral? Or is it more costly than radiation therapy? But we also have to realize that only the proponents publish and emphasize the advantages, and generally they do not take the capital equipment and maintenance cost into account. And that's something that's logic. With every new fancy apparatus, the proponents will publish their initial results. So here we see what the Moore paper from Mayo, Greg just talked about it, taught us that surgery alone is much cheaper than if you do surgery with radiation, surgery with chemoradiation, and chemoradiation alone. I think that's not really very, very big news. And they state that an algorithm of transoral surgery with adjuvant treatment, as indicated by the pathology, is more cost-conscious than an algorithm of treatment of all oropharyngeal carcinomas with chemo-RT. But we are not treating all oropharyngeal carcinomas with chemo-RT. We can do surgery with other approaches, the laser, for instance, and we sometimes use radiation alone without chemo for a superficial T2 and 1. You can do without the chemo, so there goes this argument. The latest report, also referred to already by Richmon et al. In the Laryngoscope of this year, they looked at a cross-sectional analysis of more than 9,000 patients who went surgery for an Oropharynx carcinoma in 2008 and 2009, and they used discharge data that are out there from a US nationwide inpatient sample. And TORS was performed in 116 cases, i.e. 1% of all the the cases. Admittedly, TORS had a lower gastrostomy tube placement rate, tracheotomy rate, and non-routine discharge compared to patients undergoing not TORS procedures. It was associated with decreased length of hospitalization and costs in this series, but what did they really take into account by measuring these costs? Surely I would say that this was a highly selected sample, 1%, and not representative for the entire population. And again, we don't need very expensive chemorad for every oropharyngeal cancer patient. Chris Holsinger, just recently in Liverpool at the European Conference on Head and Neck Oncology, he argued that there is substantial long-term toxicity of chemo-RT. We know this, it's well described, and we should avoid it if possible. We are living in a whole new world with 85% or so HPV positivity for oropharynx, at least here in the States. In Europe, it's still a wee bit lower, and that we can do without toxic treatment, and that the IMRT machine, Greg told us that as well, needs to be purchased and maintained. But I argue that the IMRT machine is used much more efficiently than a robot for, let's say, some hundred cases per year. Another paper, White et al., she looked at 4 centers that used the robot for recurrent oropharyngeal carcinoma after non-surgical treatment. The series was matched to the same amount of open cases, and indeed the surgical time, blood loss, hospital stay, tracheostomy, and PEC rate were significantly lower. But this can be done only for very selected cases where there is good exposure, no trismus, and of course no bony involvement, because then the robot is simply useless. So TORS versus IMRT, and I looked at what was out there in the literature. There is a French paper that describes that the mean cost of treatment in their group of patients treated by TORS was about 20,000 euros. And what's also written is that that should be compared to 35 fractions of 2 grays of IMRT with CT scanning, mask preparation, etc. It's about half the amount. So there goes that argument. What about thyroid surgery? It's very popular in Asia, and again, in Korea, you are reimbursed 4 times the amount if you do it transaxillary as compared to the open approach. But in the US and Europe, patients usually have a different body habitus, resulting in more complications and sequela, and it's twice as costly. And one of the surgeons from MD Anderson, Nancy Perrier, she tried the robot for this indication, but abandoned it because of all these complications and the cost. So there's another argument down the drain. So what about larynx? Just a few words. We can see here from a Belgian series that compared robot to the laser and open approach for larynx cancer, that the robot was almost twice as expensive, and that the main part of the cost of the robot surgery was driven by the equipment itself, whereas for the other approaches, the personnel costs were the drivers for the cost. So even when they doubled the yearly caseload, used the shortest operative times, and they were not able to reach cost equivalence. TORS is more expensive than the standard approaches and mainly influenced by purchase and maintenance costs again, and of the proprietary instruments. Further trials on long-term outcomes and costs following TORS are needed to evaluate its cost effectiveness. Those trials are ongoing or in preparation, some in the States, Canada, the UK, and in Europe, and hopefully they will bring us some more information about effectiveness on the one side and the cost comparisons on the other side. In conclusions, it's a good and but also expensive tool, and as long as the institution bought the machine, I think you may surely use it too. But if you ask the question, is it cost effective? No, it's not yet cost effective. And the outcome therefore needs to be demonstrably and significantly better, or the cost of the system needs to be lowered before it will become a cost-effective way of treating our patients with oropharyngeal or thyroid or whatever tumor. So usually they ask the last speaker to bring up the best arguments because that will stay with the audience in their mind, and I've hoped to have achieved that. Thanks for your attention.